Participants are joining.
Yeah, thank you very much. Just for a couple of minutes and people can join in. We have about like 250 participants to join our webinar. That is the news in the morning, but now I believe there's more.
Great, yeah.
Many people are joining now. Shall we start?
Sure.
Yeah.
When you are ready.
So good afternoon, everyone. Special panelists, distinguished speakers, and all the participants. So first of all, welcome all of you to the AHLA, Asian Health Literacy Association webinar 2020, with the theme is a public participation in the COVID-19 1 year on, which is organized by the AHLA and with the support from the Taft University and many other institutions in Taiwan, Vietnam, Indonesia, Philippines, Hong Kong, Malaysia, and many other countries. So thank you very much for the President Peter Chang and Director General Huang and Dr. Widows, Dr. Ngok, Dr. Ting Ting Sus, Dr. Patrick, Dr. Pauline, and my co-host Alex Chen. So now I would like to introduce Professor Peter Chang to have the opening remark to our webinars. Your stage.
Thank you for Dr. Duong and co-moderator Dr. Eric Chan from Japan, and all the invited speakers, distinguished guests for this special webinar. AHLA has been 10 years since its instauration, and but this year was one of the most difficult years for us. We usually getting together every year in October until this year, and we're looking forward to the pandemic will be gone away by all the effort contributed by all the individuals and scientists around the world. It has been a great honor for AHLA to host this important event very close to the end of the year, and also through these particular tough years for everybody in the world. I believe AHLA would like to initiate this discussion between scientists and the public, particularly public participation. I know public engagement, shared decision-making is one of the key issues we have been working on for many years. I'd like to see this event would go to a much wider dissemination with a wider participation from more than 10 countries in this webinar. And I believe this will be one of the very important events that we continue working on our difficulties and challenges ahead of us. The vaccine might be available, but we have to keep all the public continue their preventive measures, social distancing, and personal hygiene. These are all essential. And I believe AHLA has the responsibility to work with all the countries, all the expertise, as well as the public, to conquer and to resolve this challenge ahead of us. I thank you so much for the moderators, the initiator, and all the speakers for today. And I hope to looking forward to your participation. Thank you so much.
Thank you very much, President Peter Chang, for his opening remark. And now we can go to the scientific program, and since Professor Director Huang Yinghui is already joined us. So first of all, I would like to introduce Professor Huang Yinghui. He's the Director General of the Health Promotion Administration in Taiwan. Over the past 2-3 decades, he devotes himself to the health promotions, and he got so many awards and also the achievement in the scientific and also many other in the university and also the government. And I sit in his lectures and conference so many times, so admire him. And now I would like to introduce his talk. Is about hacking the COVID-19 pandemic, the building the public trust in Taiwan. So the stage is yours. Please share your screen and you can start to present your topic.
Okay, thanks for the introduction. Now I'm going to share my screen. First of all, I'm quite, I've used a lot of time, many times to prepare, because hacking in COVID-19 pandemic is quite a challenge topic for me, but I hope that I can share some experience in Taiwan. So in this moment, can you see the screen?
Yes,
the whole
clear.
screen.
Thank you.
Okay, okay, thank you. Sorry. Next one is about the present situation of the COVID-19, what's happening globally and also what's happening in Taiwan. And you notice that just 3 days ago, we have a confirmed case of 716 cases, but most of them are import cases, not the domestic. And totally, from the beginning of this outbreak, we have 7 deaths since then. And we have no lockdown in Taiwan, and everybody working at the same gathering the same way, and also have meetings, conference, concert, except we have to wear the mask during the meeting together. And just this article just released from New Zealand in October 21. Actually, New Zealand got a very positive for their success in COVID-19, but they said in this article they said there is another island nation some 900 kilometers away, that is Taiwan, that they think that there was something that you can learn from Taiwan. And also from the Lancet region of health in Western Pacific, also in October, just the last month, in October 21, they analyzed the regions that caused that what was happening in Taiwan. And as I highlighted, the public health infrastructure, as well in Taiwan since the SARS many years ago. After that, we established our public health infrastructures. And so they enabled Taiwan as a fast coordinated response, especially in the domain of early screening, effective methods of isolation and quarantine, digital technologies for identifying potential cases, and mass use. And this is the regions that they analyzed in this the Lancet report. So when we think about what is the critical success factor in Taiwan, you can see in the center that there are 3 domains. One is the recognized crisis, because we have the experience in SARS, so we have notified the pneumonia of unknown cause in Wuhan, in China in early January. There is recognized this situation. And also that we rapidly start with the border control, especially case identification and contaminant. And also we start with the resources allocation for the logistic and also the operation. And the green part is the communication and politics. Especially we have almost every day, actually this is every day there's press conference, press meeting, and announce about what's the situation. And everybody have awareness. So the 3 factors is a strong risk awareness, open government, and also public participation and hard work. So I think that this is 3 most important factors that we get a very good control. When talking about the new normal in Taiwan, in Chinese, we said that there's 6 domains very important for our daily life. The first in Chinese is the cloth, but it's a similar pronunciation as medical. So when we think about the medicals, the food, the housing, the transportation, education, entertainment. So let me see what happened in Taiwan. For the medical part, we noticed that in the first 3 months, there are about 5 million times visit decrease from the COVID-19 in the first 3 months. And also there are trends or pattern of the clinical visit. Something they noticed that the dermatological department and mental department increased the visit because during this attack, people use the wash the hands, use the alcohol. So there are a lot of allergic reaction, and also the anxiety and the tight relationship with the families are maybe one of the issues causing the mental issues during this COVID-19. And also for the cancer screening, because cancer screening is not so urgent. So we noticed that for the oral cancer screening decreased about 1/3. For the breast cancer screening decreased 13%. For cervical cancer screening decreased 15%. So totally we decreased about almost 16% for the cancer screening during this attack. But we think that we have to use some more smart method. So we use a personal app. Actually, in recent few years, the Taiwan developed using with a very advanced in high technologies. So the IT is very developed quite successful. We use a lot of mobile service for control of the NCD, for example, for diabetes. And use a diabetes self-management program for using a mobile device. And they can, even though they do not visit for the clinical visit, take the clinical visit, but they can use the app for diabetes self-management and also communicate with the clinicians during this period. So even they do not go to the hospital because of the high contagious possibility in the hospitals, but they can still get in touch with the physicians and also share their result of, for example, so the diabetes sugar control with the physician using the digital method. And I think as a health literacy, I think that this is a very successful way. This study was done by Behavior Insight team from UK. And in March this year, the BIT team compared 10 educational pamphlet materials for washing hands for 10 countries. And they compared whether they're understandable and reasonable and can very easy to read and remember. This is what we think about health literacy is very important. From this comparison that the study, Taiwan ranked #1 during this comparison. The second is the Singapore and third is the NHS from the UK. So the information developed by Taiwan that from Taiwan CDC that showing a very clear information for how to wash the hands, how important that they can keep your distance. So all these things are doing as a study and using compare with the 10 different different sources of the material. The so-called PDIC, and I think that's very interesting and also easy to understand and valuable for compare with the for using the concept of the health literacy. How about the food? And also we noticed that many people cannot go out the big gathering in the early of this outbreak. So most people are asked to work at home and also stay at home. And then they could, in the past, they just eat in the restaurant or buy some of the lunchbox. But now they have to stay at home. So we start with develop some of the cooking. People lost their ability, I think, lost the ability to cook by themselves. They just go to buy things in the past, but now they have to cook at home. So we develop some of the materials, ask them to cook the healthy eating. They can use a lot of, for this lady, you can notice that she have to learn how to cook, to get the skill of cooking at home. Or they can call for Uber Eats or Food Panda that's deliver of the food to home. This is a very interesting cartoon picture that the lady go to see the doctors that asking whether this boy or girls after 3 months quarantine, and the physician said that it is fat there. That means that you have to eat very careful during this period. Don't get fat. So we have a lot of information that deliver. And also that we ask the people, the elderly, they have to do the eating together is a social connection and social participation. But during this period, most of the activity are closed. And then some suggestion that you can use the app. They can use, for example, to use the video video that you can share your eating with each other during your eating your breakfast. Just a few days ago, when I was go to the Aboriginal county, and they said that in that Aboriginal county, the elderly, almost 90% of those elder people are using social media with communication. So nowadays, the elderly are using the social media quite commonly, and this is raised the question about the digital literacy in the future. And how about the living? We do some of the material for teaching people to, when you work at home or stay at home, because some of the gym are closed. So to make your home as your gym, that you can exercise at home. This is one of the communication video. And also for transportation, it's really easy. You notice that most of everybody doing taking the public transportation should wear their mask. And especially from the December 1st, we start to ask, because we noticed that the outbreak of this the COVID-19 in most of the country increasing recently. So we start another requirement that December 1st, that we have to wear the mask for situation. For example, the entertainment or in the office or learning place or place of consumption, you have to wear the mask. People said, why we follow that mask? Because I think the culture issue is very important. You can notice from these pictures that for the Western culture, for Dr. Sorrow, there's a very famous people to call Lake of the Sorrow or the Batman. They just wear the mask on the upper, cover their eyes. But for the East, we always cover our mouth. So this probably this is the culture of the different issue that we can wear the mask and decrease for the transmission of the virus. How about the education? Actually, during this period, before this period, actually, we developed some of the cyber learning, so-called distance learning or video conference and distance learning. But in the past, we just put everything on the web and the people read it, but it is not so effective for learning. So it is better that we start with the program with the so-called online synchronized team-based learning, and with small team and online interaction, they put the education more effective. Another cartoon is that we just ask someone to sit on the screen and that read everything, because people get boring when they get looking at the screen. You have to some method for teaching the distance learning. And how about the entertainment? Actually, as I mentioned, that we have closed off some of the activity center. Even the opening of some of the activity center, they're difficult to access for some of the training program. So we have a web-based training program. In the left photo, you can left pictures that you can see a lot of elderly people watch the screen. This is on the web base, and the speakers are on the screen, and they teach them how to do the exercise or do cooking. So we have developed some of the distant learning program that is easy access even in the remote county or Aboriginal county. And another very successful program is that we noticed that the elderly just like to watch television. But now there's due to the advance of technologies, the television channel is start with using some of them so-called Android system that is interactive. So we put a camera over the screen of the television, and then you can use the remote control to communicate with your family or even your neighbor through the television. And this is very welcome by the elderly because they are familiar with the watching television. And once they not use the iPad or use the cell phone, but now they can use the large screen, the television, communicate with their family and also with the neighbors, how the activities, sharing experience. So this is another thing that you use the television, home TV interactive technology platform. This is one thing that we share the information. For example, what is the Wuhan or COVID-19? So you pitch a lot of information through the television or video. We have a program, so WalkCare. WalkCare is a program that there are a lot of speakers on. You can pick up them. The cost depends on your time and your interest. So there are a long list of training programs that we've developed on the web. So this is easy for access and also interactive. So the new normal is just like post of digital at home and also digital health reform. I think this is the last line. I've written articles that new normal, but actually this is the new future. So we have to get a substantial response to the COVID-19. And there are another article calling that use rapid design thinking to overcome COVID-19 in the medical education. Not only for medication, but even in our daily life. They emphasize that it makes some change. But instead of reverting back to the pre-COVID-19 status, we have to face the new future. This is my final slide. Thank you for your attention. Okay. Finish.
Thank you. Okay, so thank you so much, Dr. Wang. Thank you very much for sharing Taiwan's successful manners actually for the new life, for new normal for Taiwanese people. So Taiwan has been very successful in preventing a COVID pandemic happen in Taiwan. But so now Taiwan is also preparing for another new normal in order to actually prevent the second and third wave of COVID-19 pandemic in Taiwan. So thank you very much, Dr. Director General, Dr. Wang, Director General of Taiwan Health Promotion Administration. Okay, so let's go to the next speaker. It is our privilege to invite Dr. Patrick Koh, and he is the assistant professor of the Hong Kong Polytechnic University and a School of Nursing. So his topic is about online health information satisfaction and digital health literacy in the Chinese people with chronic diseases and the COVID-19 pandemic. So thank you very much, Patrick Koh, for your precious time today. So now the floor is yours. Thank you.
Thank you, Dr. Chen, for your kind introduction. So today I'm going to share with you our study about the online health information satisfactions and the digital health literacies in the Chinese people with chronic diseases amid the COVID-19 pandemic. So this is a collaborative project including different regions, and we have members from the mainland China's, Hong Kong, Macau, and also from Germany. So before I talk about my studies, maybe I briefly share with you about the current situations in Hong Kong. So this figure shows us the confirmed cases in Hong Kong in 2020. So we remain a low level of infections in the September and also October. But the new wave of COVID-19, or we call it the fourth wave of COVID-19, has hit Hong Kong very quickly. So the numbers of new cases rise again in the end of November. So the new cases actually is related to a cluster of infection in a dancing studio in Hong Kong. So a group of people got infected there and then spread out the diseases again. So the government now has implemented again all the social distancing measures. So all the schools suspended at this moment, and also most people are working from home. So we can say that it is a quite critical moment in Hong Kong now, and no one knows when the fourth wave of outbreak will end in Hong Kong. So let's go back to our studies. And so our study is looking at the health literacies in the people with chronic diseases. In the outbreak, the people with chronic diseases are always regarded as the vulnerable populations. As we can see that a few epidemiological studies has already shown that the comorbidity would increase the risk of developing some severe complications, such as some multi-organ failures or respiratory failures. Also, we can see that the people with chronic diseases have a higher mortality rates compared with the people with low comorbidities. And you can see the mortality rate in China here. The people with the vascular diseases have the highest mortality rates, followed by the diabetics and also the hypertensions. So because of it, the people with chronic diseases usually pay more attention to the information about the COVID-19. However, during the lockdown, many people, including the people with chronic diseases, could only receive the health information at home through the internet, such as they're using their smartphone or tablet. Although the people could easily obtain the health information about the COVID-19 from the internet at home, but we can see that there are a global epidemics of information spreading across the online platform and also the digital medias. And WHO has also labeled this situation as the infodemic, the short form for the information epidemic. So during the infodemic, a large amount of disinformation and also misinformation were circulating through the internet. So it poses challenges for the people to obtain some correct or accurate information about the COVID-19. So we conduct a cross-sectional online surveys in order to understand more about this information satisfactions about the COVID-19 in the people with and without chronic diseases. And also we try to explore their information searching behaviors and also their digital health literacies. And we also try to identify some possible predictors of their information satisfactions. So we adopted the convenient sampling to recruit people from different sources, such as personal network, some education institute, and also some NGOs. And the target populations are those adults aged 15 or above with internet access living in Hong Kong, Macau, and also mainland China. So the measuring tools we use is developed by the COVID Health Literacy Consortiums. In the surveys will include their demographic status, the source of information seekings, and the COVID-related topic search, perceived information's importance and satisfactions, their digital health literacies, and also their psychological well-being. But because of the limited time, I will not present all the results with you today. I have highlighted some key points here. So here is the result. You can see that there are about 4,472 participants completed the survey, and in which there are about 882 people with chronic diseases. And when we compare their demographic, we can see that the people with chronic diseases has a lower level of the information satisfactions and also poorer psychological well-being compared with the people without chronic diseases. And this table also shows us the source of information on the COVID-19 obtained by the people with the chronic diseases. And you can see the majority of the people with chronic diseases receive the health information from the social media, followed by the use of some search engines. And we also see that there's no significant difference between the people with higher satisfaction rates and lower satisfaction rates regarding their use regarding their source of information source. However, when we compare their digital health literacies, we can find that the people with higher information satisfactions would have a higher digital health literacies. And also in the logistic regression, we also find that the digital health literacy is a strong predictor of their information satisfactions in the people with chronic diseases, followed by the frequency of search on topics about the symptom of COVID-19 and also the perceived importance of learning quickly from the information searched. So from these surveys, we can see that less than 50% of the participants were satisfied with the online information related to the COVID-19. And the people with chronic diseases has a lower level of the information satisfactions. And although even though we know that there are overwhelming of the misinformation on the social media, a majority of the respondents, including the people with chronic diseases, obtain the health information there. And previous study from the literature has already indicated that over 98% of the people in China use the social media to seek the health information. And we found that the major concern of the public is whether they could quickly learn from the information. Most of the general public want some quick and fast information, and it is one of the predictors of their information satisfaction. However, the information in the social media are usually eye-catching, but most of them are lack of the quality or reliability. We need to screen out the misinformation ourselves. At the same time, from this study and also this COVID-19 pandemic, we can see that the poor health literacy is an underestimated public health problem around the world, especially in the mainland China and also Hong Kong. And previous study also indicated that people with poor digital health literacies will encounter different difficulties in understanding the health information, and they may take some inappropriate protective measures, eventually putting them to be more vulnerable to the COVID-19 infections. Actually, we cannot eliminate all the misinformations, but what we can do is to enhance the public digital health literacies to fight with the infodemic. And in this study, we can also see that the people with the chronic diseases have a poorer the psychological well-being compared with the general populations. And the stress management or some stress reduction method is also a key research during the pandemics. So the COVID-19 also highlighted the need of the in enhancing the public mental health in the vulnerable populations during a pandemic. So we need to focus on both physical and psychological well-being during the pandemic. So because of the infodemics, the Hong Kong government also created some thematic websites to help the public to obtain more accurate information about the outbreak. And for example, this website can provide some latest information in Hong Kong and also written in different languages such as Thai and also English, etc. And we can know from the website, we can also know that where can we have the early testing, screening, and how can we fight with the virus. So this study has shown us the majority of the people with chronic diseases seek the online health information from the social media, but the overwhelming of misinformation and also disinformation on the social medias may pose the challenge for the people to obtain the reliable and also relevant health information there. And digital health literacy is a strong predictor and also a significant predictor for the health satisfaction of information. So we cannot eliminate all the misinformation, but what we can do is enhance the public digital health literacy, especially in the people with chronic diseases. And besides that, we also this study also increased our awareness in the mental health problem on the vulnerable populations during a pandemic, such as the people with chronic diseases. So today I just share some of the findings with you about our study. And this study is published in the accepted for the publication in the Journal of Nursing Scholarship, and you can have a look there. It will be published in next year in January, so you can have a look about our studies for the details. And this all of our sharing. Thank you for listening.
Thank you very much, Professor Patrick Kaur, for your sharing, and congratulations on the publication with these studies. Actually, Hong Kong is one of the members in the COVID-19 Health Literacy Consortium. That consortium is now we have 50 countries to get involved, and we are going to analyze the data in multiple countries very soon. And Hong Kong is one of the successful chapter for this consortium. And with that, thank you very much for Professor Patrick, and I hope you can stay with us. I know you have a class later on, but you can stay with us and answer the question from the audience. All right, so the next speaker is she's Professor Ting Shu. She's a professor now in the Monash University in Malaysia and the former vice president of AHLA. She involved in so many multi-country studies and also get so many success in study and also teachings. She's going to share with us a new topic, not on the calendar. It's about staying active at home. Sorry for the audience, the participant, that in previous, the program is about relational community engagement and COVID-19. However, the staying active at home is more attractive and is more important than the other. So Professor Ting Ting Su like to share with us this topic. So the stage is yours. Go ahead to share with us. Thank you.
Okay, good afternoon, Duong. Can you hear me well?
Yeah, very well.
Okay, can you see my slides? So good afternoon, everyone. Thank you very much for inviting to share a piece of research we conducted in Malaysia. So, and my sincere apology for changing the topics in the last minute. We are doing relational community engagement research, but the findings are interim research results. So I thought it would be nice, to share the findings, from the completed study. So the full title of my topic is Staying at Home, the Impact of COVID-19 Movement Restriction on Physical Activity in a Low-Income Semi-Rural Population. So this project is a collaborative research project with the University of Bristol. So I would like to acknowledge research team member Laura, Ruth, Miranda, Charlie from the School of Policies at University of Bristol. And I also, And I also thank Mr. Roshidi for doing data analysis for me. The funding from this research is from the Elizabeth Blackwell Institute at University of Bristol. So a little bit of background. Even before pandemic, globally, 25% of adults are physically inactive. That means, people have less than 150 minutes of moderate and vigorous physical activity per week. And it makes increasing risks of early mortality and non-communicable disease, NCD. And during the second wave of COVID-19 pandemic, Malaysian government implemented movement control order. So in my presentation, I'm going to use MCO. So MCO is a movement control order. Actually, it is a total lockdown. It is followed by conditional or recovery movement control order. It's a partial lockdown. So it's like any other countries, across the globe. Almost, all governments implemented movement restrictions. So the downside of the movement restriction is that it can reduce physical activity, particularly in the semi-rural populations, where the majority of physical activities occurs during out of home work. So aim of our study is to conduct a survey within an ongoing longitudinal cohort in Malaysia to explore the impact of the movement restriction or MCO on changes in physical activity. And then we plan to inform policy actions in low and middle income countries when easing movement restriction to reduce negative consequences while avoiding a further wave of infection. So that means that we have to balance between life and livelihood, and then also preventing infections and then other collateral damages. And sample size, we calculated the sample size 1,000, assuming to detect a fall of physical activity of 8 to 15%. So this is a study setting. So this is an ongoing cohort. We call it Southeast Asia Community Observatory. It is established by Monash University, Malaysia. We follow populations, 40,000 residents in our cohort from birth until death. So this is a good opportunity to conduct nested cross-sectional study and nested cohort study. So we did a follow-up telephone survey with 2018-19 health survey participants. So we have their data, we have very rich information. So we follow up those people using validated global physical activity questionnaire GPAC. So the study was conducted June to July 2020. So actually 18,000 population participated in health round 2018. And 15,000 participants are eligible for studies because they give us a telephone number for future contact. The participants can decide not to give us telephone number. So only 15 people give us a telephone number. So we selected around 2,600, randomly, but only 1,400 are contactable. And then finally, 1,007 participants consented. So I'm going to show a bit of finding. So characteristics of the participant. So we compare with 2018 and then current survey in 2020. It seems, it's a kind of very much, comparable with, social demographic and then educations and then the physical activities levels. So during 2018, 22 people has a physically inactive, and then our survey participants in 2018, 20 people has a physically inactive. So it seems we can draw a kind of representative samples, from the big cohort. So this is the changes of the physical activity status. The participants are classified as an inactive if they engage in less than 150 minutes of moderate to vigorous physical activity per week, according to WHO definition. So during lockdown or during MCO, 44% of people are physically inactive. And then after post-MCO or during partial lockdown, 34% of total participants are physically inactive. Once we compare to 2018, 21% are physically inactive. So 55%, continue going for physically inactive, but some people are also moving to be active even during MCO. And then people who are active, physically active in 2018, it is reduced to 59%. So that means, 41% of people are physically inactive anymore. So I think this graph can explain better. So we compare 2018, the people physically inactive, 20% of people are physically inactive, but during total lockdown, it gone up more than double. The 44% of people are physically inactive. And then once a lockdown is a little bit eased, that means in the partial lockdown, still it didn't reach back to the normal physical, usual physical activity level 20%. It is still 34% of people are still inactive physical activities, even post lockdown. So once we look at the differences of male and female, so male is blue, female is red, and then green is a total. So once we compare that, we expected the physical activity dropped so much, a lot. And then after post MCO, it is increased, but still didn't reach to the levels. So before lockdown, the male has higher physical activity levels, 1,090 minutes, average minutes per week. But it's during lockdown, the drop of the physical activities amongst male is a lot higher than female. And then even after lockdown, the males' physical activities are still lower than female. And let's look at how much we lost in the physical activities according to the domain. So if you are familiar with the global physical activity questionnaires, there are 3 domains of the physical activity. Number 1 is a work-related domain. And then number 2 is the transport, people who walk or people who use the bicycles, to go to outside. And then the third one is the sports or leisure physical activities. Once you look at semi-rural populations, even their physical activities for transports and their physical activity for sports and leisure are even low before COVID-19 pandemic. So although it is dropped, it is also still drop, but the most important drop of the physical activity is a work-related physical activity. So you can see, the steep drop of the physical activity levels, from baseline. Although it is increased a little bit, it didn't reach back to the usual level of physical activity. So we would like to know which kind of population has more reduced in the physical activity. So we use bivariate data analysis by using t-test and one-way ANOVA. And then we also do the multivariate linear regression controlling for all confounders. And then we compare with the before COVID-19 and during MCO, and then before COVID-19 and post-MCO. There is not much significant difference of the physical activity drop according to the age group. And then there is no significant difference of the physical activity drop according to the education. So the most important drop in the physical activity levels is in the male. So even controlling the confounders, is the significantly different. And then also post-MCO, the male physical activity drop is a lot, higher than, stay a lot higher than the female. As we expected, people who are working, their physical activity level drop is a lot, higher than homemakers and then other people. So these two findings are really interesting and important findings, for us. Although there is no significant differences, it seems, people who are obese, they can still maintain their physical activity level compared to underweight and overweight. And another one's NCD, people who has, hypertension and diabetes, their physical activity level drop is, a lot less than people who has no non-communicable disease. It was not according to our expectation, because our expectation was, people who are obese, people who has, NCD, they will drop a lot of physical activity, but the finding was against to our expectation. And then the people who are obese and the people who has hypertension and diabetes, they still can keep their physical activity level during COVID-19 pandemic. It might be due to a lot of, promotions, health literacy intervention, targeting to people who has an NCD. I think that's such kind of health literacy promotion activities really pay off during COVID-19 pandemic. So this is a kind of passive physical activity questionnaires. Nowadays, during COVID-19, a lot of online surveys are conducted. Of course, this is a way we can get the information from people. So this is a way people ask, the level of physical activities, their passive level of physical activities. Because of MCO, I have been less physically active. Can you see the findings? Although their physical activity levels, drop enormously, the majority of people perceive their physical activity didn't change. The 46% say not at all, and then only 18% say only a little bit, and then only 8 to 9% say their physical activity level drop. So it is a totally different with the information we collected with the global physical activity questionnaires. So another side of the coin is eating. So Dr. Wong also rightly mentions, eating and then also physical activity. So we asked, the people who eat less than it should be. So 93% of the population say they never eat, less than it should be. And then 96% of people, it never happens, for them. They can eat, when they are hungry. So if you know Malaysians, this is not unsurprising. So eating is a best part of social and culture in Malaysia. So even in the pandemic, people still continue eating, although there is a lot drop of the physical activity levels. So fruits and vegetables, I think in terms of health promotion aspects, this is very interesting finding, and this is also encouraging findings. People stay at home, people eat home cooked meal. So we can see the eating 5 serving of fruit and veg. Before pandemic, it's only 2%. And then during COVID-19, so it's increased to 16%. So I think this is a very much encouraging finding. So this is a piece of research we want to share with you. So before conducting that survey, Malaysia has reported 7,000 cases and 114 deaths. So before conducting our survey, in the semi-rural regions like Johor, where SICO is located, there are fewer COVID-19 cases, only 700 cases. So in the area of low virus transmission, the consequence of movement restriction must be carefully balanced against infection risks. And targeted movement restriction according to COVID-19 incidence is highly recommended, which is currently practiced in Malaysia for the wave 3. Currently, we are COVID-19 wave 3. And then currently the movement restriction is according to the zone. So if there is a lot of COVID-19 cases, it is a red zone, yellow zone, and then green zone. So the movement restriction is according to the COVID-19 incidents. And then the government implementing targeted movement restriction. So this is very encouraging for the physical activity. So we encourage using robust assessment tool like IPAC. It is highly recommended rather than using one items of passive physical activities. And health promotion message on how to actively stay at home are essential to encourage people to stay physically active during pandemic. And last but not the least, return on investment in improving health literacy among people with common NCD is shown in our piece of research, because the people who has hypertension and diabetes, people who are obese, they are still physically active during pandemic. Thank you very much. Thanks for the organizer and thanks for the audience. I'm happy to answer your questions if you have. Thanks again.
Thank you, Dr. Tuyen V. And actually, in Japan, we also observe like lots of workers, because they have to work from home. And also, as you mentioned in your study, that most of the activities comes from occupation. So maybe we can see that Japan maybe can have more like an overweight issue after MCO. But it seems that actually people are eating healthier compared before MCO. I think it's a very good sign. People they do less exercise, but like they are eating healthier. That's a very good sign. So I think we're gonna open some Q&A later after the by the end of the session. So thank you, Dr. Tuyen V. And now it's our privilege actually to invite the speaker from the industry. I mean, we have so many speakers from academia, but today now we have a speaker from the industry. So I would like to introduce Mr. Leo Lee, and he's Executive Vice President of American Vaccine Biologics Corporation Taiwan, and this vaccine company has been becoming very popular in Taiwan because of the COVID-19 vaccine. So, Mr. Lee, and the floor is yours.
Hello, everyone. Can you see me?
Yes,
Yes.
we do.
Yes.
Yeah. Go ahead.
Okay, that's good. Thanks for your time and joining the webinar today. So I think that today I would like to share with you some concept of the vaccine, because people know the vaccine is the final solution to solve this COVID-19 pandemic issue worldwide. So everybody right now is eager to have a vaccine. Even the government, every government, they try to get more and more vaccine on the hand, even over their populations. So today I would like to share with you some basic concept of the vaccine. So we all know that the SARS-CoV-2 is the virus that causes COVID-19, and this time the vaccine developer, they try to target the so-called S protein on the virus to produce the vaccine, to develop the vaccine. What is the S protein function? The S protein is like the key to open the door on the human cells. When the human cells, the door was open, then the virus can infect the human being. So that's why you will see later that every vaccine right now in the developing progress, they all target S protein as their antigen. So there will be 5 vaccine platforms worldwide to develop SARS-CoV-2 vaccine, including the first platform is so-called DNA and RNA. The most famous vaccine candidate is the mRNA vaccine. There's 2 developers, Moderna and Pfizer BioNTech. That you see that recently the British government has approved the Pfizer mRNA vaccine, and right now they begin to their vaccination program. The second one is the viral vector vaccine platform. The most famous developer was AstraZeneca and Oxford team. They use the adenovirus to produce the SARS-CoV-2 vaccine. The third one is a protein subunit platform. This is a more traditional vaccine way to produce vaccine. The developer was like the Novavax and Sanofi and MVC. MVC is the company that I work for right now. And the last one, the virus platform, is that they inactivate the whole virus, or they produce so-called live attenuated vaccine. The most popular vaccine developer was the Sinovac. Actually, right now, most of the China vaccine producer, they all use this way. But the question is that this kind of vaccine, the side effect will be worse than the RNA vaccine or viral vector vaccine or protein subunit vaccine. So people also know that this time we don't have too much time to go through the traditional vaccine development progress, like the preclinical, then phase 1 clinical study, phase 2, phase 3, and licensures. So traditional way is take around 10 years to have the new vaccine. So this time, the regulatory authority, they use the way so-called EUA, Emergency Use Authorization. They try to shorten and parallel all these steps to that the vaccine can be launched as early as possible in the world. So you will see that from the preclinical study and the clinical development, they will use so-called interim review way to speed up all the process. On the other hand, for the vaccine producer, for the manufacturer, they will begin to produce the vaccine candidate even in the clinical study phase. That means the vaccine producer also take the risk once if the study fail. They will also have a lot of waste in the production side. But this we don't have any choice. That's why everybody spent a lot of time and money try to shorten all this period. But it does not mean this vaccine was not be supervised by the regulatory authority, because just like our company, every week we need to have a face-to-face meeting with our regulatory authority to discuss every step. They try to ensure that all the steps are still on the right track and under all the regulatory requirement. So later right now you will see that the mRNA vaccine has launched, just like in the British, the Pfizer mRNA vaccine already begin to vaccinate. This is no doubt that from this year, December, the mRNA or even Moderna in the US, they say that they will get a license by the end of this year. It will be launched and begin the vaccination. And next year, Q1, the adenovirus vector, just like AstraZeneca and Oxford, this team, they will also launch in the market after the EU health authority give the approval for them. Then next year, Q2, the subunit vaccine will also be launched. So you will see that Novavax, Sanofi, and MVC vaccine will be launched in the Q3 next year. It means that if every vaccine producer can successfully and smoothly launch in the market, that means gradually the lockdown issue will be solved. But it also depends on the awareness of the people who would like to vaccinate this kind of vaccine. So when you will be curious about that, for the vaccine efficacy, how we calculate it, because from the media, you will see like the Moderna, their vaccine efficacy is 95%. So how we calculate the efficacy here, I would like to share with you. It's very simple formula, like attack rate between the vaccinated group divided by the attack rate between the unvaccinated group in the real world, then you will come up the percentage. That means that you will have the vaccine efficacy, this number, to prove this vaccine can be worked. Safety is the most important for every vaccine developer, because we vaccinate is the healthy people. We are not vaccinate just like the medicine for the patients. So safety always is the priority for the vaccine developer during the vaccine life cycle. So we closely watch the safety issue. But on the other hand, you will see that people are hesitant to vaccinate the new vaccine because they receive many news or media reported there will be some adverse event. Here I would like to clarify the adverse event, it means that any healthy problem that happen after vaccination, it can be directly linked to vaccine, like the side effect, or unrelated to the vaccine, or unrelated to the healthy problem. So people need to know that when the media report the adverse event, they need to know that it may not caused by the vaccine. So every adverse event will be investigated by the professional healthcare workers. So they will identify is vaccine related or not related. This is the most important concept we need to have. Herd immunity also is a key for the worldwide, that if we would like to solve the COVID-19 problem, because the more people vaccinate COVID-19 vaccine, the more people will be protected. The herd immunity, the concept is very simple. That means the more people, if in this group more people vaccinate vaccine, then they will protect the people who did not vaccinate the vaccine. So the vaccinated people will block the virus transmission. This is very important. Just like in a family, if the father, mother, or the children vaccinate the vaccine, then they may protect their grandma or grandpa. So that's why the people also need to know that they have a responsibility to vaccinate the COVID-19 vaccine. So finally, this is my last slide. The COVID-19 pandemic is the health crisis, and it's already caused the economic issue. So we need to have the vaccine to solve all these problems. And I think that everyone in this meeting, we need to tell people that the right concept of the vaccine and encourage people to vaccinate COVID-19 vaccine, then everybody can return to the normal life, just like in the past. So this is my final slide, and thank you very much for your time.
Thank you very much, Mr. Lee. You are on the track of the successful for the vaccine in Taiwan. And with your sharing, we received like 10 questions from the participants. So be patient to answer all of them. I will send the question to you later after you introduce the next speakers.
Okay.
Yeah. So the next speaker is Dr. Pauline Ubio. She's the faculty of the College of Public Health, University of Philippines. Before, she's secretary of the Philippine Department of Health. Philippines is a big man in the health sector in Philippines. She's going to share with us the topic related to impact of the population health literacy on COVID-19 pandemic. So Dr. Pauline, the floor is yours. You can start to share the screen and share with us. That's great. Yeah. You may need to turn on the audio, unmute maybe by your phone. Sabrina, could you help to send the...
Yes,
okay,
I'm sorry.
good.
Yes.
Yeah, it's working now.
Here.
Go ahead.
So
yeah,
you can see my slides. Thank you.
Yeah.
So the Philippines recently finished its first National Health Literacy Survey, December 2018 to May 2019, only last year. And it shows a nationwide limited comprehensive health literacy of 51.54%. And it is widely...
We cannot hear you.
Desperate in that it is actually functional health literacy.
Yeah, keep it close. Yeah,
is high. Yes, it's high in the urban areas and becomes low in the rural areas. And our new law, universal health care, is hoped to improve the Filipino health literacy, and we have included a sizable budget for health literacy in the universal healthcare law. So we hope to implement this in the next few years. The UHC law was signed in February 2019, and the implementing rules was signed in October 2019. So the goal is to provide Filipinos with basic health information to prevent disease, identify early disease symptoms and manifestation, and seek consult or health intervention as soon as possible. So this particular intervention for improving the Filipino health literacy was actually put to test during this COVID-19 pandemic. We developed a number of information education materials. So this is just an example of the COVID response plan of the Philippine Red Cross. So we're doing the 3Ts: test, treat, and trace. So that's the main goal of the government. And I think this has been properly disseminated to the people. So we have been on lockdown in Metro Manila since March 15. There was no lifting of the lockdown yet, although some of the restrictions were actually lifted. Like in March 15, there was no public transportation. Now there are. And those who are 18 years old, 21 years old and below cannot get out of the house, and 60 years old and above. But now we allow 15 years old and above to get out, and 65, up to 65. And we have mobilized like a whole of society approach. So it's everyone providing information and actually reminding other people of what to do during the lockdown. And this is the most important campaign that was launched sometime in July 2020 of the Department of Health. It's called BIDA Solution. BIDA means hero and solution means solution. So it's in English, be a solution and not a problem. So that's for COVID-19. So that's the official campaign logo for our COVID-19, fighting fake news and providing vital information, relevant education material in the quad media for all Filipinos. So this is what was done. There was house-to-house campaign, meaning all households were provided information. We had targeted audiences like the patients and the doctors. And this was done through virtual media, and also the Department of Education, since the school children were not allowed to have physical classroom activities. It was done through virtual information drive, and also we sent newsletters to the students. And then we had also some targeted audience like the BPO, the call center agents, and public and private office workers. So this is the ongoing campaign of the BIDA Solution. And we actually produced a number of materials like our face mask with the logo of BIDA Solution, and there are TV and radio ads. And we had a webinar. Okay, integrating training modules for BHW are our barangay health workers. They are volunteers in the community that provide vital information to the household. So this actually stopped, the training of barangay health workers stopped, but we now try to bring it back through virtual training, no longer face-to-face. Okay, so these are some of the areas and some of the targets. So it's really a targeted campaign. We have Super Kid and Super Teen, so that these are like cartoon heroes that the students can identify with. Okay, and existing office-based health caravans for different sectors. So there are health nutrition counseling. This used to be done face-to-face, but now everything is virtual. And then the last picture that you see here, that's an elevator sticker. So it tells everyone to wear their mask, wear their face shield, and to observe 1 meter social or physical distancing. And we have coverage of all these materials in the doctor's office. We have direct patient education and participation in hospitals and the community, and even social media through Facebook and Viber. So it's really a whole of society approach in the community, in the hospital, in the school, and in the workplace. So these are the partners. We partnered with a lot of private sector, Procter & Gamble, Ajinomoto, Johnson & Johnson, Unilab, United Home, and call center companies, and so many others. Okay, so it's a continuing effort by our partner with the Department of Health, and we hope that this will actually help in improving the Filipino health literacy. And as a result of this campaign, I think you can all see that in July, when we launched this Be the Solution, we were having a very high rate of report of new cases in August. That is our first wave. And because of the health education information campaign, it's now going down. Although it's very slow, but it's still going down. So that is the success of our health education campaign for the COVID-19 pandemic. Thank you.
Thank you, Dr. Pauline, for sharing the Philippines' very successful beta solutions actually to increase the public awareness of COVID-19 and also self-awareness of the disease, and increase diagnosis in the Philippines. That's a great success. Congratulations. So now it's our privilege to invite the next speaker, Dr. Phan Kyu, and he's president of the Board of Trustees of Haifu University of Medicine and Pharmacy from Vietnam. He's also the former vice president of AHLA. Today, he's going to share with us the COVID-19 prevention measures deployed within enterprise in Vietnam. Thank you, Dr. Phan Kyu. Now the floor is yours. Thank you for sharing the Vietnam's manners and also actions with us. Thank you.
Hello, can you guys all hear me?
Yes, we can hear you.
Thank you. So my name is Ngọc Minh Nguyễn, and I'm here on behalf of Professor Hui, who is, because of the busy schedule, cannot be here today. Today, can you see my slide well?
Yes, we can see your slides.
Okay, good. Thank you. So today, the topic that I'm presenting is about the COVID-19 prevention measures deployed within the enterprises in Vietnam.
Do you want to make it full screen?
Yes, let me see. Here you go.
Perfect. Thank you.
Thank you. So our labor force in Vietnam is take about 50.7% of our population, and most of them are employed. However, within the employed labor force, we have only 22.8% of them are trained, and the rest of them are untrained. 2020 is a very difficult year for all of us, and as we all know that the COVID-19 has been affected not only our health, but also other aspects of our lives, such as education, humanity, and economy. And 2020 is also a year that Vietnam has the highest unemployment rate for all over the decade. We have around 758,000 enterprises are activate, and 127,000 enterprises are in the industrial field with more than 300 industrial zones. So we all know that the human resource is a key asset in any organizations as well as enterprises, and caring about this key asset element is very important to us. However, under the threat of COVID-19, this assets of the organization is threatened. So here's our healthcare system for labor force. So the first level is the Ministry of Health. They are responsible for providing guidelines, regulations, clinical protocols, and send out the missions to lower level authorities. The second level is Department of Health, and other institutions will follow the Ministry of Health guidelines and develop the missions in more specific to appropriate to the local context. The CDC, it centers the occupational health protection and environment, and other 13 centers of occupational health and preventive health centers are working all together to develop the missions to more specific objectives and send the directions to the health center and lower level like community health station and other local industry area. And the last level, they all carry those missions to the daily life practice. So the initial success of Vietnam in prevent the spreading of COVID-19 has contributions of multiple sectoral stakeholders. But the key success here is the rapid responses with clear and strict measures directed by the government from the very beginning. We have the task force group formed only a week after the first case in Vietnam was revealed, and they are 24 members from 23 different ministry, departments, committees, and led by the Vice Prime Minister, Vũ Đức Đam. Also, the Ministry of Health formed the Emergency Public Health Operations Center to direct the CDC on how to detection cases, isolation, tracing cases, and also the surveillance of suspected cases and close contact group. All entry and departure internationally and domestically was temporarily restricted during this time. The compulsory isolation of 14 days after coming back from the epidemic areas, the surveillance of suspected case and close contact are strictly mandated as well. We also have the centralized isolation center and hospitals, which is received the guidelines from the Ministry of Health, develop the clinical testing assessment for suspected cases, as well as provide the clinical care to positive cases. The informations about disease prevention, confirmed case reports, and exposures findings were all broadcasted daily by almost all Vietnam social media like television, radio, text messages. We also have the national phone message from the Ministry of Health about the COVID-19 to send to all citizens. We have our waiting ringtones, well, also about the COVID-19. So when someone calls you, they can hear that information as well. And during this time, all gathering events, activities, school was canceled and suspended. So instead of face-to-face setting, we encourage the distant learning and communication. Also for the enterprises, the e-commerce was supported by the government. In this figure, you can see that how different ministries, department, local authorities, all working together in different fields, different aspects to combat COVID-19. All of them are under the directed by the task force, and we integrate the different sector like the mass media, the educations, health professions, and other aspects like the public of defense to suspend the transportations and the flights from and to the epidemic areas. Here is how the regional government office respond to COVID-19. So the Ministry of Health working with other government authorities to give a clear directive to all the citizens and lower level local authorities. The regional government office, for example, Department of Health, carry these missions with multiple measures and develop it to more appropriate in their local context. Also, they're working closely with other departments and healthcare professionals in different levels to tracing the high-risk groups, setting surveillance and isolation points. All events were forced to cancel, and we have the directive number 16 that mandates all citizens to stay home, and we have the quarantine for 2 weeks. Also, the Department of Health at each city and province will give directive to lower level local department and other coordinators. The economic zone authorities communicate with regional enterprises closely. They sharing the official information about prevent and control COVID-19, the result of positive cases, how to isolate the suspected case, and the surveillance setting for the close contact group and suspected case. They also require the report from the enterprise about all the workers, about their health reports and also their travel history. They also monitor the implementations of COVID prophylaxis at the enterprises, as well as encourage people to use blue zone next. The enterprises follow all the directions of the Ministry of Health, other government authority, as well as the economic zone authorities to build up the procedures at their workplace. They prepare appropriate supplies as well as working environment to prevent the spreading of COVID at workplace. They only inform the justified information to workers to avoid misunderstanding, panic, and confusion, and also give a clear direction and detailed criteria to protect themselves from COVID-19. Here are, we also have different support from other institutions and organizations. The National Institute of Occupational and Environmental Health created the Tuyen V, which is famous all over the world. And it's a very simple way, but very effective way to spread words about COVID and how to prevent the spreading of COVID by simple ways like hand wash, face masks, and social distancing practice. They also provide the multiple communications and informations channel at the local office via virtual communications and website as well. Other medical and pharmaceutical university also give a hand on combating COVID-19. They send out their employees, doctors, students to be our frontline workers at different stations, for example, at airports, hospitals, communities, different companies, enterprises, and in the local health station. These frontline healthcare worker is very important because they not only provide the primary care, direct people to isolation points, detect cases, as well as report and tracing cases, but they also provide the education to the citizens and other local community. So people are all aware and be alert about the spreading of COVID-19 and raise their awareness in the community. Thank you for your time, and that is all my presentation for today.
Thank you very much, Dr. Ngok. Wonderful presentation and sharing with us about the response from the entrepreneur to the COVID-19 pandemic in Vietnam. Actually, you sharing with us about the top-down and also bottom-up approach from multi-level and multi-sector approach to deal with the COVID-19. So that's why the prevalence and the incidence of the COVID-19 is relatively low in Vietnam. There will be some question to ask, then I will raise that during the discussion section. So please stay with us and answer those questions later on. The next presenter is Dr. Sarawut Bunsuk. He's here. However, he's already prepared the very nice and informative videos, and I'm going to share my screen and he's still here. If you have any questions, then you can ask him later on. Okay. So he will go into introduce himself very clearly in this video. So please watch the video. Sorry.
Audio, please. We are not hearing the audio.
Yeah, we cannot hear.
Sorry?
We are not hearing the audio.
Cannot hearing the all right. Let me. Can you hear us now?
No. No, we can't hear you.
Try closing and opening again.
Close this and
yes.
Let me share the screen. Can you hear it now?
No. Can you increase the volume inside the video? Why don't you try? Because I saw there is a volume over there.
The other is when you shared the screen, did you click audio?
Actually, can you see the slide?
Yes.
Yeah, we can see the slide, so we cannot hear.
Can you hear the voice now?
Yeah.
No.
Oh wow, doctor. We tried before, but then why cannot work? Let me try this again. Sorry for this disruption. I will do this again. Alex, can you switch off your? Okay, let's see. It's this one. Oh, sorry. I know the problem. Let's wait a moment. Okay, got it.
Experience about the overview of the COVID-19 situation in Thailand.
Look, right?
And the next is the Department of Health strategy to respond on COVID-19. And the last topic to challenge and the way forward. Good afternoon, ladies and gentlemen. I'm Dr. Slavut Bunsuk, Deputy Director General of Department of Health, Ministry of Public Health, Thailand. Today, I'm going to share with you about the strategy responding to COVID-19 in the topic of health literacy promotion and prevention measures to citizen engagement and multi-sectoral cooperation. Thailand's success on response to COVID-19 pandemic. This is outline of my presentation. First, I will share experience about the overview of the COVID-19 situation in Thailand. And the next is the Department of Health strategy to respond on COVID-19. And the last topic to challenge and the way forward. I will start with COVID-19 situation in Thailand. On the 9th of December 2020, yesterday, Thailand has 4,151 infected cases in total, with 60 deaths and 3,880 recovery and 211 patients are still in the hospital. The Department of Health Strategy Thailand, our key mission are preventing and reducing the spread of the disease by focusing in the all age group through systemic environmental health management. We also promote health literacy to the people and encourage people to have appropriate behaviors to protect themselves during the pandemic. Department of Health strategic response to COVID-19, we deploy strategies in many levels, establishment, upgrade and improve standard and guideline on public health measures for business operators to prevent transmission of the disease. Community and local, we monitor and evaluate preventive measures at establishment for health safety of public. At individual level, we created health literacy, promote public health measures, and enhance rich communication. And we promote citizen engagement and multi-sectoral cooperation for all, and implement public health measures according to public health law of Thailand. I would like to share 4 main strategies to respond COVID-19. The first one important strategy is we have developed Thai Stop COVID or TSC platform as a source of knowledge for the public, business operators and officers. We scale up public health literacy to TSC platform for business operators to comply with the standard. Users could perform self-assessment by using TSC platform. Once you go to the hotel and you notice something or want to send your complaint about the COVID-19 response of that hotel, you can scan the QR code on the hotel's e-certificate as shown on the left side to keep it as a source of knowledge for the public. If there are more than 3 complaints with the same area, the information will be sent to be further checked. For more campaigns on improving standards and guidelines on public health measures for business operators, we also enhance the standards of safety, hygiene, and environmental sanitation to set a goal of new normal. This measure has been implemented within restaurants, fish market, hairdresser, golf course, food delivery services, and more places to boost confidence of the people in using services during the outbreak and during the easing of the lockdown in various phases. Next strategy is creating health literacy and promote public health measures and enhance risk communication. We have developed knowledge, sets recommendations and guidelines for the people's daily life, and develop a comprehensive risk communication and response system or AHLA, which is reachable for all target groups. About key activity on promote health literacy, you can see on this slide, we have a campaign for enhancing Thai people to wear masks to protect themselves from COVID-19 and promoting appropriate health behaviors with 3R, which are reduce, reframe, and responsibility. We also have big cleaning campaign for public transport, shopping malls, fish market, restaurants, sport place, gym, condominium, and school. And the last one, social distancing measure. And for key activities under citizen engagement and multi-sectoral cooperation, first we try to strengthen communities' capacity to prevent COVID-19. In order to do that, we integrate work with Ministry of the Social Development and Human Security, targeting the vulnerable group in 5 areas, which are consumption or central kitchen, financial support, career or income, housing, and the last is health. Then we develop the model and guideline for empowerment of the community to promote good health and safety from COVID-19. For the collaboration among government, private sector, and Thai citizens, we join targets and plan. We have the measures or standard and a monitoring system such as risk factor monitoring, like people behavior, business operators, and the new case. Next is the study and manage the result of health impact assessment, which this should be covered at all age groups. Thirdly, respond when a case emerges after a lockdown, easing by investigating, responding to the case, and creating knowledge management for the situation, and health promotion and environment health practice on new normal, such as a light cost approach and protection and prevention new normal services. The last strategy is promoting citizen engagement and multi-sectoral cooperation. In this area, we focus on creating local mechanisms on health promotion and environment health. And we also promote and strengthen the capacity of the public sector to participate in the prevention and control of COVID-19. I will tell you about the process we use to introduce new normal way of life to Thai people. The picture below, you will see the process which begins with the surveillance, then creating measures and the standard. After that, we continue to improve it. The public side to the people along with setting up monitoring system. Lastly, we announced as a new normal and enacted on Public Health Act. My last slide is about the challenge and way forward. Recently, Thailand found new cases of COVID-19. The way forward to tackle this situation include monitoring the situations and promote health in the new normal practice to improve public confidence. The second method is promoting health literacy and good environmental health for every sector for health protection, including wearing masks in public place and washing hand hygiene of public place, cleanliness, minimize risk from common contact point, and maintaining environmental health standards. And the last point is cooperating and communicating with network partners and Thai citizens to prevent spreading of the disease. This is the end of my presentation. Today is Thailand public holiday, and I joined the conference in a remote area which had poor internet signal. So if you have any questions, you can leave the question to the organizer or contact me directly by email in this line. In the next 2 years, Thailand will host Asian Health Literacy Association Conference in 2022. It is my pleasure to welcome you all in Thailand. I hope that the situation is safe for travel at that time, so we can see each other face to face. Lastly, I would like to give my sincere appreciation to the organizing committee for arranging this webinar. Stay safe and thank you very much for your attention. สวัสดีครับ
Sawadee-krap. So thank you very much, Dr. Boon Suk, for sharing amazing lessons from Thailand. Since you are here, so later we have some questions, and please respond to the participant. Alex?
Yeah, Sawadika, so thanks for Dr. Boon Suk actually to share Thailand very exciting products actually to stop COVID-19. And also we look forward to see any good results for the future. And for the next speaker, it's our privilege to invite Dr. Widoyono, and he is the Mayor Assistant of the Economy Administration and Development and People Welfare in Indonesia. And he is also the former head of the health department of Semarang City. And today his topic is going to share with you the impact of the local law enforcement. Actually, it's a very specific term, local law enforcement on COVID-19 pandemic in Semarang City and in Indonesia. So Dr. Widoyono, now the floor is yours. Thank you.
While waiting for the slide ready, I explained the Opera C Justitie actually is a local law enforcement in English. So that is his presentation. Yeah, go ahead.
Can you see my slide?
Yes, we do.
Okay, good afternoon. Nice to meet you, everyone. Honorable committee chairman, speakers. I will share the topic, the role of local law enforcement. We call it in Indonesian language, sorry, Operasi Justisi on COVID-19 pandemic in Semarang, Indonesia. So, and on March 12, 2020, WHO declared the first case in Indonesia on March 2. Right now, it's around 557,887 cases, and active cases was 77,969 on December 4, 2020. COVID-19 in Semarang, Central Java is the province with the third most confirmed cases of COVID-19 after DKI Jakarta, the capital city of the country, and East Java, the main island in Indonesia. The first case in Semarang City, the capital city of Central Java, was reported on April 9, 2020 with 36 confirmed cases of COVID-19. Our major regulation number 28 of 2020 concerning guideline for implementing community activities restriction. We call it PKM. What is PKM? Ladies and gentlemen, no cities in Indonesia have implemented lockdowns. Several areas with high cases have implemented PSBB or large-scale social restriction. Our local authority face a dilemma. On one hand, the case must be declined. On the other hand, the economic must continue to run. So in the end, the city government chose PKM or community activities restriction. PKM is the middle way where community activities continue to run, but by enforcing strict health protocol, masking, physical distancing, and hand washing. The government of Semarang City only carried out PKM. PKM consists of activities including stopping the implementation of school activities, restricting work activities, limiting religious activities, limiting activities in public places, limiting socio-cultural activities, and the movement of people using transportation modes. In industrial areas, there are restrictions on employee attendance, physical distancing, and health protocol. Restriction on opening hours of restaurant until 10 p.m. The capacity and the implementation of health protocols such as providing safe hand washing at the entrance door, checking a temperature, and using the mask. Community activities can be shown in this figure in modern department store, and on the road, the police stopped the driver. The local law enforcement, we call it Operasi Justisi, is an option made by Semarang City government to conduct synergic and efficient monitoring and supervision. These activities, joint activities consisting of the Civil Service Police Unit or Local Service Police Unit, the Transportation Service, Road Service, related regional apparatus such as a police and even army and regional unit. The Operasi Justisi, which was carried on May 4, 2020. The operation is carried every 3 days, every 3 times a day, and divided into 3 sections, 4 to 6 p.m., 6 to 8, and 8 to 10 p.m. The local illustration, local law enforcement or operasi justisi, you can see the figure officers interview violator of health protocol, especially mass and busy night centers and on the road, on the crowd, busy centers, and on traditional market. The punishment of violator of the local law enforcement, especially they have to wear the mask. You can see that pray together, clean the road, and this is a specific meeting. Officer brings health protocol violators to pray at COVID-19 special grave, because at first the community refused the body of the COVID-19 victims buried there. So our local government built a special grave for the COVID-19. And push up 50 times, push up and sweep the grave, the cemetery. The method, data analysis from Operasi Justisi report, which carried out from May 4 to November 12, 2020, 60 times randomly in busy center in the city of Semarang. This is not a well-prepared study, but only taking data from the result of operations Justisi. So I apologize if there may be incomplete data. The total sample was 7,957. The data recording during operation Justisi was whether the sample wore the mask or did not use the mask. Data for sample that do not mask will recorded according to their ID, home, and work address. Evolution trend were used to analyze the package organization. It can be seen that the characteristics of health protocol violators, you can see the gender, males and female, and ages, most often 16 to 20, occupational, the most private sector staff and the district. The percentage of violator based on address found that most often, namely by 43%, were from outside for the city. The most sub-district resident did wear masks were namely Tembalang, Peturungan, and West Semarang. Semarang city is the provincial capital where there are many large companies operating in Semarang, and many of the employees come from outside of the city surrounding to the city of Semarang, namely Kendal, Demak, and Semarang Regency. The characteristics of the community who do not wear masks are 86% male and 59% ages 16 to 20 years. The frequency distribution, you can see that it can be seen the frequency of in May, June, July, and August is still very low. Only 4 times. This is because the priority of the program by the Semarang City Authority government is still preparation for care and treatment of COVID-19 cases at the hospital. And another thing is how to increase the number of hospital beds due to the limited isolation rooms in almost all hospitals at Semarang. The highest number of used masks in October by 72%, and the highest number no wearing masks is 60%. it can be seen that number must drop dramatically to from 60 to only 31%, and the low figure was stayed on in the following months. And the number of related cases of COVID-19 per sub-district, it can be seen that the three highest number of violators located in the district with higher case in Semarang, which is Tembalang sub-district, Peturungan, and West Semarang sub-district. Based on this test, Operasi Justisi statistically showed the significant on increasing the number of using mask 96.4% and decreasing the number of non-mask by 96.3%. The previous research has found that the use mask has a portion reduced viral reproduction rates in the general population, and the combination of using masks and social distancing which significantly reduce the burden of COVID-19 in society. The use of masks has become major strategy in prevention and respiratory infection. A study concluded that during the COVID-19 pandemic, it is advisable to use masks in public places as a measure to prevent the transmission of pandemic. And the previous study also on a health behavior found that female gender had better knowledge about health than men. Men are less adherent to health prevention behavior. And the reason why the percentage of men who do not wear the mask is higher than female in Semarang, maybe most of men in household in Semarang is work outside from the home, and meanwhile the woman is household not work in outside. The district with the most positive cases COVID-19 are densely populated areas. Based on the data from Semarang City, Population and Civil Registration Service, where Semarang district is sub-district with the largest number of villages, 16, with the population at 157,581 people. Tembalang district and higher, and Peturungan district is highest. Based on the statistical result, the use of mask during COVID pandemic was the balance with the implementation of the Operasi Justisi. It was found that the existence of Operasi Justisi would increase the use of. This is our measure in Semarang City, and this is local law enforcement in traditional manner. Thank you for your attention. I'll back to this authoritative moderator.
Thank you very much, Dr. Wido Yono, for your presentation. That is wonderful to share the local government, how they get involved to deal with the pandemic, and certainly you got some success on the plan. And with that presentation, we now move to the discussion section. There's many questions to ask the speakers, and I'm going to ask Professor Sabrina to help with some Q&A. And first may come to whom, then please.
Well, thank you, distinguished speakers, and for our engaged participants. Our first question was early, and this is for our speakers from Taiwan, Professor Wang and other distinguished speakers. The question is, in terms of vaccination for COVID-19, how wide will be the vaccination campaign in Taiwan? Do you feel there will be acceptance or reluctance to take the vaccine? who would like to answer that question? Professor Wang or other distinguished speakers from Taiwan?
I think Professor Huang, Director General Huang, may answer this question from Taiwan. Hello. Professor Huang. Are you there, Professor Huang? He may not.
Do we have another speaker who would like to address that question?
Yeah, how about Mr. Leo Lee?
Alex, yeah. He's a dual citizen, Taiwanese and Japanese.
No, I mean Mr. Leo Lee, and he's from the pharmaceutical company for vaccine. So, Mr. Lee, is Mr. Lee still here with us?
Mr. Lee is not here. He left to another meeting. If there's
I have another question, perhaps,
we may move,
for any of our speakers. The question is, the participant would like to know the plan for COVID-19 testing in your country, while now the vaccine campaign has been started. So will testing continue in your countries while the vaccine campaign has started?
the vaccine.
Professor Su, Tintin Su from Malaysia, do you know if there's going to be vaccine hesitancy in Malaysia, or can you comment on how the campaign will, whether they'll still be testing now that the vaccine campaign has started?
Oh, well, the vaccine hesitancy, we don't have a proper evidence, but, you know, by talking to the people, some people has, you know, a bit vaccine hesitancy. So I think this is because of the vaccine is produced, you know, very rapidly. So people are asking, you know, each other whether it is, you know, effective, you know, whether it is safe. But COVID-19 testing is still continuing, and particularly for the immigrants, you know, workers, because currently we are in the third wave of COVID-19 in Malaysia. So, and then many immigrants, you know, workers are tested positive. So the COVID-19 testing is still ongoing in Malaysia. So, and Prime Minister promised that we will be getting vaccinations in first quarter of 2021. But of course, you know, the priority groups rather than the whole population.
Very good, thank you. Another question for the any speaker is, what would you like to encourage to promote a healthy lifestyle in the new normal life beyond COVID-19?
I think this question will go to Professor Tintin Su.
Okay, thank you very much. I'm talking. Actually, the healthy lifestyle is very difficult. So even before COVID-19, you know, even the usual lifestyles, you know, it's very difficult to promote healthy lifestyles. You know, although people know, it's very difficult to follow. But according to the piece of research, you know, we conducted, so of course, you know, I mainly focus on physical activities, you know, but not a lot on diet. And we also have some studies, you know, people don't eat, you know, outside or less eat frequently outside, you know, they have a less cardiovascular, 10 years cardiovascular disease risks. So, and then during COVID-19 lockdown, you know, a lot of people eat inside and then people cook, you know. So I think during lockdown, cooking home meals, I think it can go towards the healthy lifestyles. And then particularly during COVID-19, so, people try to eat, more veg and more fruits because the people know it can prevent, it's just a good, preventive strategy. But normally people don't pay a lot of attention to, eating fruits and veggies. So I think some people are even, more health conscious. So I think that health promotion messages, to keep healthy, to keep fit, stay active, I think we have to keep on doing. So currently, a lot of people are using, digital platforms, to encourage physical activity. So maybe I think it's better to use digital platforms, to encourage physical activities in new norms. So for me, I stopped going to gym. So what I did it, I follow some of the exercise program from YouTube and then keep physically active at home.
We do have another question from a number of people of how can we apply for a webinar attending certificate? Perhaps the AHLA leadership can respond to that question for everyone.
Yeah, thank you for that question. And I received so many emails of you sending. So please email me with your name and affiliations so we can reply to that with the name of you and also the affiliation in the certificate. Certainly we will do that. Thank you.
I do know we have a number of questions that were asked about vaccines, and I think those were answered in writing. Is that correct?
Yeah. I think yes. We can ask the speaker to respond to that probably on our AHLA website to those questions. However, now vaccine is a Pfizer and many other companies, they start to have stage 3 clinical trial, and some companies successfully can deliver the vaccine to the pupils, but we still just see the only efficacy of the vaccine, just like Mr. Lee mentioned that if we want to know the effectiveness of vaccine, and we see how many people can take the vaccine, and we can see whether it's effective or not. But another comment for that, for those who ask related to the vaccines, we are not expert in that. However, I attend another conference and we discussed quite deeply about the vaccines. And one of the experts in the field mentioned that vaccine alone, it doesn't work. Vaccine alone, it doesn't work. Even you have vaccine, but now people vaccinate, right? People vaccinated, then it work. So it's vaccination is work, but vaccine alone doesn't work. So between the vaccine and vaccination, there's something in between. That is health literacy. So health literacy is also very important, not just only for the individual, but also for the system, right? For the system, how you're going to improve, empower people, empower the public in order to have better understanding about the vaccines, right? For example, media now, they may have not really real information about the vaccine. Sometimes they just say the vaccine have a side effect. But just like one of our speakers mentioned that the side effect or adverse effect of the vaccine could be the vaccine itself and other factors. So we need to investigate to see the effectiveness of the vaccine. So from individuals, we need to empower people, improve their health literacy levels, vaccine literacy, right? insulin literacy, and nutrition literacy, many other things. At the system level, we have the organization, institutional health literacies, and of course, some of the experience sharing across the countries. We see that all the government get involved. So that is the systematic levels of health literacy, right? The government, the ministries, any other sector to get involved to improve people health literacy in order to have better collaboration with the program. You see, in Taiwan, we don't have a lockdown, but the prevalent and incident of the COVID-19 in Taiwan very low. But in the United States, you may have like second wave of lockdown. Germany, you have second time of a nationwide lockdown, but the incidence still very high. So the question is why this social distancing, why lockdown doesn't work, right? So this is about many other behavior, not just only, you know, the government orders and also some rules applied by the ministry levels or government levels. So we want to ask the new question whether there's any other factor. So health literacy and also the people behavior and healthy lifestyle is very important to contain this terrible, you know, and pandemic. So I think there's many other questions coming up over here. Some asking about the vaccine. There's about 10 questions related to vaccine, and one of them is about the cut-off point of the herd immunities. And there's a guideline from WHO. I just sent you on the chat box, and the threshold is suggests at least is 80%. And in previous one, of course, we cannot expect 95%, right? But it's 80% should be good enough. That is a suggestion from the WHO. Certainly, there are some arguments about the cut point for the herd immunities. Since there's many other questions related to whether the village health volunteer, the role of the village health volunteer in terms of the health literacy amidst the pandemic certainly is very important, right? Just like explained earlier, the multi-level approach is can work. And there's one question related to because since Dr. Ngoc sharing the experience from Vietnam, and there's a question like is there a coordination with the other Southeast Asia countries so that they could benefit from development and handling the COVID from the Vietnam approach. Could you like to answer that question? Dr. Ngoc. Yeah.
Can you send me the questions again? I don't see it in the question box.
Yeah, it's not. They put in the chat box. It's so crowded, so I just copy it here. Is there a coordination with other South Asia countries so that they could benefit from development and handling the COVID from the Vietnam approach? If you're aware any collaboration, yeah.
Yeah. So I will answer these questions on my knowledge, because of the coordination is not only part of Vietnam, and also the context in different countries is very different. So for example, in our country, we in our political view, we have only one government, one party. So it's going to be more, easier for the government to set the control and one directive to all citizens and to all departments, to all ministries. But maybe in different countries, it's not the same way. Like in different countries, they may have the two parties or even multiple parties in different political views. So this is not going to be practical for them. The other part is our citizen awareness and behave is also different. So for coordinations, I think it may need to be more of a compatible context. Because, for example, wearing face mask in our country, wearing face mask is very a regular activities, and it can be applied for anyone. But for example, in the Europe or in America, they have a very strong debating about if they should wear face masks, because for them it may raise a different problem. For example, robbing or another bombing or something like that. So for the coordinations, we are most likely depends on if the other country is willing to work with us, and so we I think the Vietnam government is really appreciate the corporations and willing to share all our experience. Thank you.
Thank you for the answers. And I think the time is running out very soon, and it's already over the quota, right? 2 hours. We will going to answer those questions haven't been answered somewhere on our website, and we also let the speakers know about the questions. And thank you very much for attending the webinars, and I wish you all learn something during this webinar, and hopefully there's some collaboration after that in terms of the research and also clinical practice and also policy sharing. And do anyone have some last words to talk to the participants?
Yeah, so, and also thank you, Dr. Tuan, actually mentioned about vaccine and also health literacy. I mean, it has been debating in Japan about if we have a vaccine, do we need to have do we need to wear a mask or all this kind of PPE or the personal prevention? It's definitely yes. I mean, because we couldn't just like the HPV vaccine. We have HPV vaccine. We don't need to wear condom. It's not right, right? So all these kind of prevention manner we still need to apply. Vaccine just the other manner actually prevent us from being infected. So health literacy would be very important at this moment, that if we transmit the wrong message to the elderly, especially in the UK right now, they're saying that, oh yeah, you have vaccinated, you are totally 100% immune. It's a wrong message, a dangerous message for those elderly, because they will go back home to be infected by their family, and then they are not wearing a mask, they are not cleaning their hands, and they will receive lots of virus. And we don't know the efficacy, how long the vaccine will last. And we even don't know actually in the real life how effective the vaccine will be. So this is very dangerous. Maybe we can reduce the symptom and the mortality rate of the elderly, but it doesn't mean that we 100% protect the elderly. During the past, our vaccine experience in history, we never say vaccine would be 1%. 1% actually prevent us from being infected by virus. So I think actually health literacy would be very important by communicating to the public that although we have vaccine, this is another matter, but we still need to wash our hands and social distance need to keep, and to protect ourselves, and also to ensure actually to monitor our body temperature, etc. All the measures should be applied. This is for actually to reduce the mortality rate for each individual, and also to protect the elderly and also voluntary groups. This is my personal opinion. Thank you.
Thank you very much. Anyone to say anything? Okay, so this is already too many knowledge share, and so with that, I on behalf of the AHLA, thank you all, the speakers, sponsors, supporters, and participants to join our webinar 2020. I could say it's a last minute, and also it's a success webinars, and hope you all healthy and success in your life. And of course, we'll get over the COVID-19 very soon. And we'll see you in the next year conference, hopefully we can do that. That is the International Global Health Literacy Summit, a very big one. Is the whole world will meet in Taiwan, and the next after that, next year's 2022 will be in Thailand, probably. So stay healthy and peace. Thank you very much. Bye bye.
Bye.
Bye.